everyone. Assalamu alaikum. This is Dr. Tazeen from Study Medic, your mentor and course director at Study MRCPI. And today we are here again with another session for the YouTube series for all MRCPI OSCE aspirants who are preparing for their exams. So if you have not subscribed the YouTube channel of Study Medic, subscribe now and just click on the bell icon so that you can be notified for the new upcoming sessions of the OMR series, which is specifically designed for all OSCE aspirants. In this session, we have Dr. Priyanka with us, who would be the examiner in this session, and I will be playing as role player. Before starting the session, the message for all OSCE aspirants is that keep your passion and dedication alive and just have faith that you are capable of passing this exam, and definitely success will be yours. Just keep on working hard and just keep on revising the things which you have to do. So here we are going to start this session. So thank you so much, Dr. Priyanka, for joining.
Thank you.
Hello, this is Tazeen. I am one of the exam going candidates. I have read the instructions and I am ready for structured discussion.
Yes. So after going through this case, so what do you think that when will be the TH more preferable than the VH?
Thank you so much for the question. There can be, as this is a case of total abdominal hysterectomy in which patient has to undergo, so there can be certain situations when total abdominal hysterectomy is more preferable as compared to vaginal hysterectomy. This can be a situation when malignancy is there, where adequate staging and debulking is needed, or the uterine size is more than or it is equivalent to 12 weeks of pregnancy, when the surgical technical difficulties can be there, or if there is history of significant endometriosis, pelvic inflammatory disease, or previous surgeries are there, and it seems that the vaginal route would be technically difficult. A narrow pubic arch can also be among one of the reasons, and it is also it gets technically difficult to remove the ovaries through vaginal hysterectomy. In those cases as well, total abdominal hysterectomy can be preferred.
Sure. Very good. So when do you think of this abdominal hysterectomy? So when do you think you will do a total hysterectomy or a subtotal hysterectomy?
The decision of total and subtotal hysterectomy, first of all, it all depends upon the patient's preferences as well. Then it depends about the history of the cervical smears, that what was the situation of the previous cervical smears, and whether the last smear was normal or abnormal, or if we are anticipating any difficulty during the surgery, like previous surgeries are there, or pelvic inflammatory disease, or advanced endometriosis is there, or the patient is obese, which makes difficult to remove the cervix, or when we meet the intraoperative difficulties like large fibroids are there, or we met adhesions, then also subtotal hysterectomy can be carried out. Whenever we have to go for subtotal hysterectomy, as we are leaving behind the cervix, so patient should be informed of pros and cons of leaving the cervix behind, that likely it would be shorter time period for the surgery, bleeding would be less, and there is less risk for the visceral injuries as well, less adhesions, and post-operative fever is also less. But the patient can get bleeding, menstrual bleeding. They have to continue their cervical smears, and if in the future any cervical pathology is there, then they may need another surgery, which can be among one of the risks which can be associated by leaving behind the cervix.
Yes. So what factors will affect your decision to leave or to retain the ovaries or to remove the ovaries?
The decision of conserving the ovaries or removing the ovaries, first of all, it depends upon the woman's preferences and her fertility concerns, that whether she wants to remove the ovaries or she wants to conserve the ovaries, and whether her family is complete and what are her preferences. Then if we are leaving the ovaries behind, then definitely operative time would be short. There are less chances of heart diseases, or the patient may need a delayed need of hormonal replacement therapy, as we are conserving the ovaries. But if in the future she is developing any ovarian pathology, then she may need another surgery, or this can be difficult surgery due to previous history of hysterectomy. Also, the age of the patient is also important, that what is the age of the patient at the time of surgery. And pre-operatively, if there are any risk factors like history of breast, colorectal, endometrial or ovarian cancer in the family, or any gene mutations if they are there, then the ovaries should be removed. Intraoperatively, the generalized look of the ovaries, that whether they are healthy looking or if they are suspicious looking, then the ovaries should be removed in these situations as well.
Yes. So what are the pre-op measures that you want to take for this patient?
In the pre-operative period, first of all, the detailed history of the patient is very important to know that what actually are the risk factors, if there are any risk factors there for the patient, which can be difficult, which can cause any technical difficulty during the procedure, and what actually is the indication of the surgery. That is very important, and it should be made sure that patient is provided with the detailed information, and she is provided with patient information leaflet, and she has signed the consent by knowing about all the pros and cons of surgery, what complications can arise, and what can be the duration of her hospital stay. Her health and medical conditions should be optimized. If any comorbidity is there, like hypertension, diabetes, or anemia, anemia should be corrected. Her diabetes and hypertension should be controlled, and anesthetic review should be there. If she has any known allergies, that should be documented. What is the suitable time of allergy, that should be documented and informed to the patient. And if she is taking any medications like any blood thinners, that should be stopped, and patient should be informed about the suitable time, and the procedure should be explained to the patient. If there is any history of previous surgery, that should also be documented.
Yes, very good. So now you have done the pre-op, you have admitted the patient, and now the patient is planned for surgery and is in theater now. So can you take me through the procedure till you close the abdomen?
Okay. So first of all, in the pre-operative period, pre-operative medications, I will make sure that pre-operative medications has been done for the patient, like antiemetics, antacids, and antibiotics. WHO surgical safety checklist sign in and time out would be signed. Preferably, the anesthesia would depend upon the decided in close liaison with the anesthetist, and patient would be in the supine position. Proper draping, cleaning and draping of the patient, and catheterization would be done. And incision basically depends upon the surgical expertise, also as well as the indication of the surgery. If the size of the fibroid is larger or extensive surgery is needed and we are expecting adhesions, then vertical incision can be carried out. Vertical incision can give us good exposure, and it can be extended from the xiphoid till the pubic symphysis by winding around the umbilicus, but it has poor cosmetic results, as the healing and healing also takes time, and also with the midline incision, the risk of adhesions is also there. Then it can be transverse incision as well, which can be done if the size of the fibroid is not larger enough, or we are not expecting much adhesions. This can give us good view of lower GI tract as well as the pelvic organs, and it has good cosmetic results as well, and less pain and less risk of adhesions in the post-operative period. Once we have opened the abdomen through the transverse incision, there would be abdomen would be opened layer by layer, and there would be proper orientation of to palpate the uterus to see that whether there is any other pathology or undetected pathology is there. Then the uterus is actually lifted with the straight, so with the coccyx at each side of the cornu, and then first of all the round ligament is clamped, cut, and ligated. So first of all, we apply a clamp on the mid part of the round ligament we are applying, and then it is cut and ligated and hemostasis is secured. After that, in the broad ligament, basically a window is made in the broad ligament by a finger, which is passed from the behind below the infundibulopelvic ligament and above the ureter. And then a large clamp is passed medial to the ovaries if the ovaries have to be conserved, and lateral to the ovaries if the ovaries needs to be removed. And then this ligament is clamped, cut and ligated. After that, there comes bladder. The bladder is separated with the sharp dissection. We use the scissors to dissect the bladder at the utrovesical fold, and then the bladder is separated. And after dissection, with the use of spongeon stick, we reflect the bladder down as much as possible, as this can reduce the bladder as well as ureteric injury. After reflection of the bladder, the uterine artery is clamped, cut and ligated. And after that, there comes the clamping, cutting and ligating of the paracervical tissue, the cardinal ligaments. And this releases the uterus, and it reduces the backflow. And we place a straight clamp medial to the uterine artery pedicel along the paracervical tissue, reaching but not including the vaginal angles, and we incise it medially. Uterosacral ligaments are also clamped, cut and ligated in the similar way, and we remove the uterus and the cervix, open the anterior and posterior fornix, and we ligate the pedicels, and we secure the hemostasis. After removal of this, the vault is basically closed with the continuous interrupted or locked sutures. We can close the vault, and then approximation of the cardinal and uterosacral ligaments is done to prevent the prolapse in the future. And we irrigate the abdomen, we check the hemostasis, no drains are placed, and we close the rectus sheath. And if the subcutaneous fat is more than 2 centimeters, that is also closed. And we monitor the patient for observations of her blood pressure, pulse rate, her intake output charting, and WHO sign out is done.
Yes, very good. So to prevent any ureteric injury from happening, so how you will identify the ureters?
Basically, when we are making a window in the broad ligament, it is separated into 2 sleeves, and then the loose areolar tissue can be dissected down to the retroperitoneal space, and the ureters can be seen in the upper pelvic course lying close to the infundibulopelvic ligament. And then also it should be kept in mind that there are 4 areas of the ureteric injury: the pelvic brim, where the ureters comes into close proximity with the infundibulopelvic ligament, then lateral to the cervix during division or ligation of the uterine artery and uterosacral and cardinal ligaments, and near the uretrovesical junction. Less often, the injuries can also take place in the ovarian fossa if we are doing the dissection of endometriosis or some ovarian cysts or remnants.
Yes. So now her surgery is done. So how will you manage her in the post-operative period?
In the post-operative period, first of all, the uterus is sent for histopathology, and we will make sure that the histopathology form is appropriately filled. Documentation of the procedure would be carried out. Patient's observations would be monitored. Appropriate IV fluids, antibiotics would be carried out. Early mobilization and thromboprophylaxis risk assessment would be done, and good analgesia would be provided to the patient. Good hydration and compression stockings can also be provided to the patient. Catheter would be removed as early as possible, and debriefing of the patient should be done about the surgery. And once the discharge criteria is met, that the patient is mobilized, pain-free, she is able to take orally, and she has passed the flatus, then she can be discharged, and proper follow-up plan should be given to the patient, along with explanation of red flag signs, that if she develops any shortness of breath, leg pain, or there is bleeding or feeling of unwell or fever, then she has to contact on the provided hospital number, and she has to report back to the hospital.
Yes. Yes, very good, Dr. Tazeen, you performed very well. So
Thank
here,
you so much.
I would like to give feedback. So yes, you have passed the station. So Coming to the your feedback, so you have answered specific pertaining to the each question, so that should be there. So if it is asked about pre-op measures, so you will answer about pre-op, intra-op, then intra-op. So yes, the answers were correct regarding the TH, which is preferable if the uterus is more than 12 weeks, or if there is any ovarian lesions, or in case of any adhesion. In that case, you answered correctly that the TH will be preferred. Even in cases the total and subtotal, you told correctly, if there are if the patient is undergoing subtotal hysterectomy, then they need to have cervical smears, especially. So that was good. Regarding ureteric injuries, also the points you mentioned correctly. And even the post-operative management, the IMUs charting, and also the input-output, even the clinical governance points were answered very beautifully. So well done, Dr. Tazeen.
Thank you so much, Dr. Priyanka. Thank you so much. Thank
Yeah.
you.
Thank you.